ACS and MI. Acute coronary syndrome, or ACS, is a set of one or more conditions that cause the blockage of blood flow to the heart muscles, resulting in a myocardial infarction, or MI. The heart is a muscular organ that pumps blood containing oxygen and nutrients to the rest of the body. The left ventricle is the main pumping chamber of the heart and contracts to send oxygenated blood to the rest of the body through the aorta. Several smaller arteries, known as coronary arteries, are connected to the aorta and supply the muscles of the heart with the necessary oxygen and nutrients. In acute coronary syndrome, there is a blockage in the blood flow through the coronary arteries, usually due to an atherosclerotic plaque, a coronary artery spasm, or a coronary artery dissection. In atherosclerosis, the continued deposition of a fatty plaque results in the narrowing of the involved coronary artery. Rupture of this plaque results in the formation of a blood clot, thereby causing a blockage of the involved coronary artery. The formation of a blood clot is the most common cause of a coronary artery blockage. Other less common causes of coronary artery blockage include a coronary artery spasm, which is triggered by drugs, smoking, cold weather, or extreme stress, resulting in a sudden tightening of the coronary artery, or a coronary artery dissection, in which the inside wall of the coronary artery separates, resulting in a blockage to the blood flow. Such a blockage to either of the coronary arteries results in oxygen and nutrients failing to reach the part of the heart supplied by it, causing the death of the heart muscle, a condition known as myocardial infarction. Symptoms of a blocked coronary artery include sudden pain or discomfort, tightening, or a burning sensation in the chest, known as angina, which may extend to the upper abdomen, shoulders, arms, neck, or lower jaw. Angina occurring at rest or as multiple episodes, preventing even moderate physical activity, is known as unstable angina and is commonly observed in acute coronary syndrome. Other symptoms of acute coronary syndrome include 1. Breathlessness, 2. Dizziness, 3. Sweating, 4. Nausea. Treatment of acute coronary syndrome, or an MI, usually involves the following. 1. Oxygen therapy, to increase the amount of oxygen delivered to the blood and heart. 2. Aspirin or antiplatelet therapy, to prevent blood clots. 3. Thrombolytic therapy, such as TPA or streptokinase, to break up existing blood clots. 4. Nitroglycerine and morphine, to relax the coronary arteries and relieve the pain. 5. Beta blockers, which reduce the heart rate, thereby decreasing the oxygen requirement. 6. Coronary angioplasty, an interventional procedure in which a balloon-tipped catheter is inflated inside a blocked coronary artery to open it, with a stent remaining behind to keep the coronary artery patent. 7. Coronary artery bypass grafting, or CABG, pronounced as cabbage, a surgical procedure in which the blocked coronary artery is bypassed with a vein or artificial graft material in order to re-establish blood flow to the heart.
This patient is experiencing an acute myocardial infarction due to a ruptured plaque creating thrombosis of the proximal segment of the left anterior descending artery. Our current approach for patients with ST segment elevation myocardial infarction is immediate cardiac catheterization and percutaneous intervention. Balloon dilatation is first performed. Dissolution of the thrombus results in distal microembolization. Occlusion of the distal microvascular circulation increases myocardial injury, which may be reflected in further increased myocardial enzyme levels and additional myocardial damage. Following balloon dilatation, a long atherothrombotic lesion remains. Stent placement compresses the residual clot under the stent struts and causes a cheese grater effect. This results in an additional thrombotic embolization. Due to the apparent long length of the lesion, a second stent is placed. Placement of this stent also causes some distal embolization. Although the angiographic result is quite acceptable, a significant amount of residual thrombus persists, both at the stent edges and adherent to its struts. The poor distal microcirculatory flow, as assessed angiographically by myocardial blush, strongly correlates with a poor clinical outcome. Patients with ST segment elevation myocardial infarction may benefit from thrombectomy at the site of occlusion before balloon dilatation and stent implantation, thereby preventing embolization and distal myocardial injury. The same patient could be treated with angiojet thrombectomy prior to stenting. The angiojet catheter is shown here removing the bulk of the thrombus. A second pass removes more thrombus. The angiojet catheter is passed several times until the operator is comfortable that all angiographically apparent thrombus has been removed. This reveals a short, moderately stenotic plaque, which is treated with a single stent without the need for predilatation. There is minimal, if any, residual thrombus present at the stent site. Angiography following thrombectomy and stenting shows an excellent result. In summary, percutaneous intervention in the setting of acute myocardial infarction due to coronary thrombosis is frequently associated with distal embolization and additional myocardial injury. Angiojet thrombectomy reduces the overall thrombotic burden, reduces distal embolization, and its associated myocardial injury. In patients undergoing placement of a drug-eluting stent, treatment of coronary thrombus plays a particularly important role. Although proven effective in reducing restenosis, the safety and effectiveness of drug-eluting stents has not been established in patients in whom there is unresolved thrombus at the treatment site. Thrombus compressed under the stent struts may prevent optimal apposition and contact between the stent struts and the vessel wall. In this situation, the true vessel size may be severely underestimated, and incomplete strut apposition may occur. Successful removal of thrombus using angiojet thrombectomy may permit more appropriate stent selection, ensuring complete stent apposition and contact between the stent struts and the vessel wall.
Your heart is a muscular organ that pumps blood containing the oxygen and nutrients your body needs. The pumping sections of the heart are the right atrium, right ventricle, left atrium, and left ventricle. In your heart, oxygen-poor blood flows from your body through large veins into your right atrium. Next, your blood moves into your right ventricle, which contracts, sending blood out of the heart to pick up oxygen from your lungs. Oxygen-rich blood moves out of your lungs into your left atrium, then moves into your left ventricle. Finally, your left ventricle contracts, sending oxygen-rich blood out of your heart to your body. If you have heart failure, your heart has lost the ability to pump enough blood to meet your body's needs. You may have weak or damaged ventricular walls that are not able to push enough blood out of your heart. You may also have stiff and thickened ventricular walls that do not allow your heart to fill with enough blood. If you have left-sided heart failure, your left ventricle does not deliver enough oxygen-rich blood to your body, making you feel tired and out of breath. Your failing left ventricle also increases the blood pressure in the blood vessels between your lungs and left ventricle. This increased pressure forces fluid out of your blood and into your lung tissues, which makes it difficult for you to breathe. If you have right-sided heart failure, your right ventricle is unable to contract with enough force to push blood to your lungs. The result is a buildup of blood in your veins, which causes a buildup of fluid called edema throughout the tissues in your body. Over time, heart failure on either side of your heart results in weakened, enlarged ventricles that deliver less blood to your body. To make up for the decreased amount of blood, your nervous system releases stress hormones that increase the speed and force of your heartbeat. Unfortunately, the continued release of these stress hormones makes your heart failure worse because they damage the muscle cells in your ventricles.
Heart disease. It's projected that 1 out of every 4 people in the United States will die from it. And more younger people are being diagnosed every day. We find out more in today's Health Matters. Age is only a number. That's how the old saying goes. And when it comes to heart disease, that's a fact.
This past month saw individual 27 with cardiovascular pain and blockage. And we see it in 90-year-olds.
As a cardiologist, Dr. Edward Palank warns heart disease can strike anyone at any stage of life, no matter how active they are.
Just because I'm 40 and I'm playing tennis and I'm active doesn't mean I can't have a cardiovascular problem.
While heart disease is often thought of as an older person's problem, Dr. Palank says young people need to be especially on guard.
There's a lot of denial. Not going to happen to me. People are still smoking. We're seeing the incidence in women of a higher incidence of heart disease in women. And we also know there's a higher incidence over the past 20 years of women smoking, starting younger, longer periods of time.
Smoking is one of the leading causes of heart disease, followed by obesity, high blood pressure, and diabetes. He warns everyone, especially younger adults, to take a long, hard look at their lifestyle habits.
They say, well, I know I need to lose weight, but they don't. I know I need to walk, but they don't. So intellectually, they understand, they know what to do, but then they don't do it.
Since heart disease is also genetic, a one-on-one discussion with your primary care physician is also recommended.
Yeah, and if you have questions, that's what your physician's for.
Stress can also play a significant role in heart disease. Your doctor can recommend strategies to reduce your stress. Reporting for Lee Memorial Health System, I'm John Bafar.